the NCDR data set is a little limited because it's only hospital event rate that we're looking at because they can't follow them. We have the data set I showed you earlier, we do have available 30-day and 90-day major adverse clinical events for it, and we're following that and tracking it. And if a hospital varies from the standard as a worst outlier, we contact them and work with their CAT team and their directors to try to improve it, including their CQI program on a confidential basis for those hospitals so that we can continue to improve their quality. So the CAT PCI 4.4 data that we see here has the standard risk factors that are in there, 240. We've added new ones like coronary calcium score is now one of the factors that we're collecting in the state of California. So we'll know what the coronary calcium score was prior to coming in for that acute myocardial infarction, and hopefully have data looking at that to report to you a little bit later. We also look at compliance, and you can see we know the discharge medicines. So here's Tony's medicines: ACE, ARBs, aspirin, beta blockers, lipid-lowering agents, and antiplatelet therapies. And so we can see if they're approved for that. Now we know in this data set that we have, and we just received this month our last dump from last year's data, that we do a very good job in the hospitals in California in providing this. But remember, this is secondary prevention. These are people who came in with coronary symptoms or coronary events, got a procedure, and then left the hospital. Once they're in the hospitals, the high end of Sacramento, we do a pretty good job in Sacramento for that. Our risk factors that we look at are shown here that we have, and you need not look at this entire list other than to see these are our risk factors. The next is New York State, so we work closely with New York State to get similar risk factor adjustment for our mortality, and Massachusetts is seen there. We also have Pennsylvania data and New Jersey data for that. So there's basically about 4 states in the U.S. that are really doing a pretty good job at data analysis in these high-risk patients and these high-risk events that we're looking at. Here's the current risk factors that we've settled on for this last year's data, 2016. You can see they're all listed here. Each of these risk factors plays a part in univariate analysis of an increased risk of mortality or composite stroke or need for emergency CABG if you have a PCI at that hospital. And we risk adjust for each of those and have pretty good area under the curve, 0.9 C statistic for area under the curve. So pretty good, pretty well can we predict these particular events in these individuals for it. Our last data dump from last month is shown here. Last year in California, you can see we did 60,522 PCIs in the state of California. This is a little bit over 10% of the volume in the United States at this time. So California is about 11% volume of the U.S. population, and about that volume for our PCIs that we're doing. We have 8, and now, as I said, 18 hospitals are either certified or applied for our off-site programs. So those are hospitals without cardiac surgery for that. Point out from the data here a little bit, look at the individuals in the state of California at regular hospitals without off-site surgery that are doing primary PCI. Primary PCI is for an acute event that a patient comes in with a heart attack, etc. Notice 2/3 of all PCIs in the state of California are for acute events, and only 1/3 are for elective angina or an elective procedure, both at the off-site and on-site hospitals. We actually, in the off-site hospitals, do more STEMIs than the rest of California for it. So one of the reasons for off-site programs is to increase the number of areas and access to acute STEMI care. Should you get a chest pain today, it will get you hopefully closer to a place where they can correct primary PCI is a very positive benefit for reduction in mortality. If we can get you closer, time is muscle. As you know, door to balloon time are our techniques for improving it, and we're adding additional hospitals for that. So that's the high-end approach for Sacramento. That's at our highest level of hospitals and highest level of care for secondary prevention and treatment. How are we doing below that level? Well, let's look at our overall statistics for Sacramento County shown here. The average mortality for cardiovascular death per 100,000 is shown as this purple line that I have here. Notice Sacramento, shown as the bars as we go across here, has a higher than state mortality for cardiovascular death. All cause or all race mortality is higher in California. It's even higher for the black population in Sacramento at 455 deaths per 100,000. That's about 0.45% mortality per 100,000 in those individuals for that. It's higher for blacks. It's higher for whites than the rest of the state of California. And it's higher for American Indian and Alaskan Natives. So we have three populations here: American Indian, Alaskan Native, white, and black, who have the higher mortality rates in compared to the rest of the state in Sacramento County for us. And if we look at that population, what is it? Well, as we said, our high-risk group is white, American Indian or Alaskan, and black. And you see those three segments represent about 60% of the population of California. So we've got three high-risk groups here based on this data, and they represent about 60% of the population of Sacramento County for that. Now there's one other thing besides a higher risk or a pool of high-risk individuals that is shown on this slide, and that is shown over here on the demographics, and you're too small, so I'll read it for you. The number of individuals who are living below poverty in Sacramento is 18.1%. So almost 1 in 5 of our individuals in Sacramento is living near or below poverty levels for that. 1 in 5. That's a higher population or percentage than San Diego and other counties. So we're looking at a significant prospect of rolling out a plan. We have to consider how are we going to deal with those individuals who really may not be able to pay for all of the things that we're proposing. Now, Tony mentioned the risk factors. I won't go over them, but the risk factors that we're trying to reduce in Sacramento to prevent a primary myocardial infarction in those people, shown here: obesity, high blood pressure, diabetes, high cholesterol, homocysteine. Those are risk factors that Tony mentioned that all of us are aware of, and that is one of the aspects, diabetes, hypertension, dyslipidemia, that the Right Care Access is trying to correct. They contribute to, with the influence of genetics, atherosclerotic disease. So these risk factors plus age play a large part in representing as much as 60% of the risk of cardiovascular events. And I think Tony alluded to it. Salem Youssef did a nice study in 52 countries, the Inner Heart Study, and it looked at the relative risk of individual risk factors. And you can see smoking shown here. Here's the line of unity here. If the dots lie on this side, they increase the risk of having your myocardial infarction shown here. So the increased risk is associated with smoking, diabetes, hypertension, abdominal obesity, and stress that is seen here. The protective things would be diet rich in fruits and vegetables, increased exercise, and moderate alcohol there. And the last one here is dyslipidemia or high cholesterol, which is one of the highest risk factors that we see for that. Now, the important thing was this was done in 52 countries in every ethnic group that was available and studied, and there's large numbers for that. And what they concluded was that the 9 simple and modifiable risk factors that Tony talked about are strongly associated with acute MI worldwide. Strongly associated. These 9 risk factors in this analysis account for a little more than 90% of the proportionate risk globally in these areas. So if we look at the attributable risk to the population, over 90% is from those risk factors, with the implication that if we eliminate those 9 risk factors or control them, we could literally, as Tony suggested, get rid of up to 90% of the chance of having myocardial infarction. The 2 highest risks were dyslipidemia, ApoB-A1 ratio is dyslipidemia and smoking, the 2 highest risks for the attributable risk in the population. And then implementing preventive strategies based on our current knowledge would prevent the majority of premature coronary heart disease worldwide. And this is just the follow-up of all we know. If we did a better job in risk factor control, we could largely wipe out much of the increased risk in Sacramento and get closer to our achieved goal of 0 cardiovascular death in Sacramento. Now, that's what our our goal is. How good a job are we doing? Well, as Tony mentioned, here is Sacramento County, our ability to control high blood pressure. The ideal is over here at 100% on the far right. You can see that our achieving of high blood pressure control varies anywhere from 0 to 81% in the various healthcare facilities in Sacramento. So even though I've shown you that the high-end hospital treatment is very good, below the hospital level, outpatients and patients walking around in Sacramento, we're doing not as good a job as we could. We need to improve 0 to 81%. Tony mentioned in his talk, and you saw these numbers for his hospital. He slammed his fist down and said, this has to change at this point in time. And literally, we could do that now for Sacramento. Whoops. I went too fast. Slamming your fist down jumped us back. So that is controlling blood pressure. How about in the higher risk individuals, those with diabetes? Here's again control in the diabetic population. And it's again 1 to 78% in the healthcare systems in Sacramento area. So again, they're not all at 100%. They're not even at 90%. We need to move all of these bars all the way to the right so that we have, especially in the diabetic population, control of a basic thing like blood pressure in Sacramento. Only then can we get close to our goal of reducing it. So what is the problem in Sacramento? Well, again, the hospitals are doing a good job, but we have 490 clinics and offices in Sacramento that are listed there. And much of this primary prevention has to occur at the clinic level or office level in California. Hospitals are okay, but clinics and offices, we've got a big job to improve our compliance for these situations. What can we offer them? There are over 100 cardiovascular risk scores that are available and out there. And some of them are available on the internet for that. We're looking in Sacramento to come up with a perhaps simplified way of an app. Most physicians are walking around with a cell phone. Put an app on that makes it simple. Yes, there's guidelines. Yes, we have a lot of risk scores that are out there today. And these are some of the ones that you can get shown here, listed for apps for doing it. But we need to make something that's simple, that covers everything, tells you everything you need and that the physician does not, or a healthcare provider, does not have to look up guidelines, does not have to read literature to come up with. It's got to be simple. If they want to go deeper, they can, but let's keep it simple. As Tony said, you don't want to die of a stupid disease. You have to keep it simple for this situation. So we're designing an app that goes on a phone that actually covers all of the guidelines for reducing cardiovascular risk at this point in time, that a physician can carry with them as constantly as they have a phone. I'm sure all of your kids have access to cell phones. They'll be the ones, hopefully, that will be telling you what to do for this. We have other options that were mentioned. Shannon mentioned earlier a CT scan. This shows a CT scan with coronary calcium. It is a way, and it is included in the guidelines for intermediate risk individuals of trying to decide whether they should be on treatment or not, if they're intermediate risk for that.
Or if they have the early family history, right?
So intermediate risk could be a variety of situations that would put you at that. And in that situation, a coronary calcium score may be one of the better prognostic indicators compared with carotid ultrasound and CRP, may be just as good for that. So I think the question that comes to Tony, and this was about where I was going to turn the talk over to Tony, was what is San Diego doing for these type of additional looks? But realize, here's the Sacramento layout. It's not the idyllic picture that I showed you before. We have high-end hospitals, high care that's very good, but boots on the ground, we represent 1 in 5 of our individuals below the poverty level. How do we get our health care to there? So here are the metric targets that Right Access is trying to get, or Right Care, to these individuals: blood pressure control, glucose control, taking statins. But how do we administer it to this group? And I've walked to these camps and other areas. These individuals do not even have driver licenses. They can't get on Medicaid in many situations because they have no ID at that point. So getting them to that. If you walk into these camps, what do you get? Half the people won't talk to you because they're suspicious you're there to steal some of their things because they don't have many belongings at that point in time. We're talking about improving healthcare and prevention. They're interested in 2 things: access to food and shelter. And those are things that are important to them today. When we talk about an asymptomatic disease like hypertension or diabetes, that's farther down on their list at that point in time. So we do have to approach the basics of how to deal with the 1 in 5 people in Sacramento who are below the poverty level. Individuals, how do we get access to these individuals? They do not come into hospitals and talk to us. They do not seek medical care in this situation. So we do have clinics that will send out buses to parking lots in Sacramento. So this is one of the buses, Sacramento, and we'll take individuals in at that time. But as I said, many of the individuals that are there who are homeless don't feel comfortable enough coming into a clinic, even if it's a mobile clinic at that point. Some areas in Europe have dispatched drones to those areas where people have inaccessible care, and those have been shown to improve response time in those people for high-risk people. But the problem is the people I'm talking about don't even have cell phones to call for EMR at that point. So our problem at this time is here in Sacramento, very good care at the hospital level, less than ideal care, boots on the ground in California because of the diversity that we have. The diversity that adds richness to California, but unfortunately it's difficult for that. Our ideal is, can we use the San Diego model to get us back to this idyllic situation of what Sacramento should be and could be. Thank you very much.
Tony, why don't you join us back at the front for a general discussion? So we had a wonderful, exciting discussion in the car on the way from the airport. And that included me saying, I'm so excited about the progress that we made in our initial community by reducing cardiovascular events, by managing those intermediate risk factors of LDL in particular is something that Tony drove very, very hard on, blood pressure control and blood sugar control. We can take some credit for reducing events, MIs, by approximately 17%. So I said, how far can we push it? If we really did this right, if we took everything we have in the arsenal on a preventive approach, like Shannon raised the issue, and in your very first slide, it shows the people who are the highest number of heart attacks we have out there and strokes are in that low-risk category. So Tony's analysis was, it's quite doable to reduce preventable, premature cardiovascular events by 75%, 80%. So Tony, can you just expound about that a little bit? Just what are the practical tools that you would say, let's go forward, take it to the next level with these approaches? You have a mic there.
Yeah, well, the biggest variable is the patient. Think of how many people smoke cigarettes. That's got to be one of the really dumb things in the world, because not only is it bad for you, but it costs a lot of money, right? And yet, you know, it's so difficult. In New York City, they were very successful just by raising the taxes, so we could do that. You know, in the workplace, there could be a penalty. Could be a penalty if your LDL is too high or your blood pressure is too high. We could follow the Bloomberg example. We could place incredibly high taxes on unhealthy food and things. But you know, it's theoretically possible, but the data come from randomized clinical trials where the population doesn't look anything like the one that Bill showed with the boots on the ground. None of those people are ever going to be in a clinical trial.
Well, and they're not in the statistics that we're looking at that
Exactly.
that a very significant percentage of the patients, like we talk about the patients in the white space on these gold bar charts, these are the innocent lambs that are walking around that need to have their risk factors controlled. It isn't clear, according to what you've been sharing with me, Bill, and what our surveys have showed, that when a patient has a very dangerous risk factor of high blood pressure, that we as the clinical community are managing it according to guidelines.
No, Hattie.
Well, that's our statistics up here.
What you know is that their blood pressure is not at goal. You don't know it's the poor doctor who every time says to them, you got to take your medicine, and then they go home and don't take their medicine.
So,
What you know is they're not controlled, and there's a limit to what the medical community can do. They can do better, can clearly do better.
So I'm sorry we don't have Mercy with us today, but they did a survey of what their providers were doing relative to the guidelines, and they found that not only were the physicians not aware of, for instance, the appropriate guideline for African American protocols, but the MAs were not following the procedures to the extent where they went to their foundation and they retooled everything. So it's not all the patient's fault.
Oh, certainly not.
And the progress that we've seen in San Diego primarily occurred so quickly that it would have to have an awful lot to do with LDL control.
Yeah, I think what we did in San Diego was largely the physician component.
Exactly.
Largely the physician component. We get this university best practices like here, and we stole somebody from you. We stole Parag Agnihatri, who's
Our initial co-chairs, now they're clinical
he
leaders.
is so good. And
Isn't he
he's the
awesome?
medical director for Sharp Resealing. And he's a champion, and he goes back there and he says, here's what we're going to do, and he convinces all the doctors to do it. The community clinics, they took that little tall all and just AL, they took that little hypertension scheme, they were delighted, because just 80% of people, so you can do an incredible amount here, but I don't think that it's possible to ever reach the theoretical limit. I think if 75%, 80% is the theoretical limit of what you can do in a perfect world, I think if you can achieve 50, 60%, you're hitting a home run.
So before we go to Bob, I want to interpret some of the shorthand that Dr. DeMario was just using. On your tables, you have our project brief, and on the back of the project brief and on that poster, you see following evidence-based protocols. And I didn't bring them up to this desk, but they're on your tables. So let's get one for Tony. Carla, would you mind bringing us one, or some for the front table? So the tall and the all and the phase is shorthand for Kaiser did an analysis of data that actually Bob Kaplan brought to us early on in the project, and found that a combination of proactive use of medications, thiazide, aspirin, lisinopril, and a lipid-lowering agent, and that was just their way of getting to an acronym, the statin, knocked down the rate of heart attacks and strokes in their population quite significantly. So in San Diego, one of the very first things they did is they hit really hard on proactively using that medication protocol for the vast majority of patients treated by the medical directors in the university medical practices. So he has been living it for 5 years, so he can just say tall and all, and we know what he's talking about, but I figured you might not know. So Dr. Kaplan.
Sure. So it may take me a minute to spit this question out, maybe better than my so
I don't think it's on, Paul.
oh, okay, then I'll talk about it.
There's a button to turn it on.
So anyway, as Ken pointed out, I spent the last 6 years working for the federal government, and that, so my question is largely motivated by how the U.S. Preventive Services Task Force gave us such confusing guidance, particularly on uses of lipid-lowering agents for older people. And so this is really my question. I had the privilege while working for ARC to sit in on the U.S. Preventive Services Task Force meetings. And it turned out that this is a very challenging issue. So for example, that if you look at any of there's 100 calculators, but they're all some variant of the Frank-Buchanan equation. And if you look at that, age is such a dominant factor. So in fact, most things are sort of age, race, sex adjusted, but actually age, race, and sex have huge impacts. And so unfortunately, if you get to be my age, even with a perfect cardiovascular risk profile, absent age, sex, and race, you can't actually get anything other than something comes back that says, put this guy on a high dose of statin, or moderate high dose. And so the task force dealt with this, and they said, this is troubling because that essentially the advice has put essentially everybody over a certain age on lipid-lowering agents. And so they said, well, what do the trials tell us? Well, it turns out the trials don't provide much information. So that if you look at people over 70, there's the Jupiter trial. The Jupiter trial all had people who had elevated C-reactive protein. And